now have to call myself a scientist and a researcher. And as Mehita said, I've kind of specialized. I've got into the area of, some people would call me a methodologist or clinical epidemiologist. And I work very much in health policy, health guidelines, both in the country. So if people are interested about national health insurance, about evidence ecosystems, that's an area that occupies me, but also globally about how we understand the architecture of data in the world and how we can avoid duplication across countries. What do we learn from COVID about all that wasted resource going into data curation? But anyway, you asked about the quantity and quality of data. So I thought a lot about the quantity first. There's so much out there. I mean, there's a saying in my world of evidence-based healthcare. It's, trying to find the answer to a question on the internet is like putting your mouth to a fire hose. It's just tons. It's impossible. And of course, data is so many different things. It's research evidence. It's my opinion about something. Those are all valid elements of data. And I guess it's when you pose a specific research question, and it's related to health, it becomes research evidence. So endless data out there. And for example, electronic medical records. I see a number of people from the UK, South Africa, we hope in the coming months will be starting to roll out those systems related to our reform in our health system. That data that gets collected, the question is always across many countries in the world, what do we do with that data? It's just data until someone asks a sensible question and makes it into research. So the volume is overwhelming. I was just checking the facts, about 3.3 million papers published, according to Scopus, in across all fields, with engineering dominating and China dominating, followed by the US. So tons of stuff. And I know in my field, in clinical medicine, as a doctor, if I were to keep up in my field, for example, even if I was in a narrower field like pediatrics or even pediatric surgery, I would pretty much have to spend the whole week reading to keep up in my field. So that isn't sensible. So it really takes me to the field of work that I'm in, which is summarizing evidence in evidence synthesis and creating systematic reviews. So I'm not sure if that's a concept that's familiar, but really, if you try and read individual papers, it will take forever. So what you want to do is try to find a credible source where someone else has posed the same question and already try to capture and pull together the totality of the evidence on a topic. And that's a systematic review. And I love those. They're the most painful things to do. If anyone has done them, you can let me know in the chat if you have a reaction to that, or by using the reactions. If you've done a systematic review, you can put something out there. So they're quite painful, but the bottom line is once you've done that systematic review, you know everything on that topic. And so we did tons of these during COVID, not tons, I lie, but more than 80 of these we did during COVID for the national government. And they're critical questions like, how to treat COVID, what vaccinations to use, patient and people important questions like, should I use vitamin C to prevent COVID or vitamin D? So those are the kinds of questions that we were looking at in these systematic reviews, where we would pull together all the available evidence and then be able to answer those questions in the best way possible. So I think that's really important. The important thing with the systematic reviews, you don't just pull the evidence together, you also praise the quality. And so just in a nutshell, quality is very important. Understanding how credible, valid, can you believe, how confident can you be in that result? You can have tons of papers, and there are many fields where there's tons, but you can't actually trust the results. Maybe I won't mention ivermectin. So I think one analogy that I really like with understanding quality versus quantity, or magnitude, like how big something is versus how quality or credible is, the weather person, the person who tells you the likelihood of rain. So say we get on those apps and it says there's an 80% chance of rain. So that's the quantity. But if you read the fine print, there's probably a 10% chance that they actually know what they're saying, or that it's credible and that the quality is there. So that's kind of the way I try and think about quantity and quality, is that, we can say a lot about quantity and magnitude, but we can't always underpin it with the quality. So I think I'm going to stop there, Mehita and Anna, and hand over to others and rather listen in and build on that. Thanks.
Great. Okay. Suntosh?
Hi, yeah, thanks everyone. Thanks, Tamara. I mean, you kind of set up the stage for me quite perfectly for some of the things that I wanted to say, including the fact that there's a thunder outside, and my Zoom call just said that my internet connection is unstable right now because of the impending thunderstorm. Yeah, hi everyone who's joined in this afternoon, and thank you to Mehita and Anna for inviting me to participate in this very, very interesting, but also quite complex webinar. It brings together quite a range of different kind of areas of thinking. I think I'm quite interested in science communication in general because as much as I'm a psychologist by profession and training, I started out as a journalist. So my undergrad degree was actually in media and communication at the University of KwaZulu-Natal in Pietermaritzburg. And so I kind of held on to the fact that I was a student journalist right until I had to officially register with the Health Professions Council of South Africa and then officially call myself a psychologist. But I suppose because of that, in the last 20 years, I've been very interested in this relationship between, in particular, my profession, which is around mental health, and how evidence gets communicated. And I've always kind of maintained some sort of relationship with mainstream media and obviously in more recent years, social media, in trying to kind of communicate what I see as good evidence for the public, so that it increases awareness around mental health, because mental health is one of those areas of science that has integrated itself so much in pop culture that when we talk about quantity and quality, it's a bit of a minefield. I like the analogy of the mouth to the fire hydrant or the hosepipe. It reminded me actually of something one of my undergrad professors once said, which always stuck in my mind. And this was before I published anything. He said he wishes he could put a moratorium on writing for 1 year and force everyone just to read. And this was a really long time ago, and I think it speaks to this idea of quantity, that to some extent we are overwhelmed in a digital era, where we can literally Google anything, or we could enter anything into an academic database. And I mean, we could spend the whole year just going through all of those articles. And I think that's why systematic or scoping reviews and meta-analyses have become so common as well. But even then, I think, some of the critiques around that is like, is anyone even reading and integrating those reviews into mainstream practice? And how many years does it take before knowledge and all this quantity actually kind of makes a tangible difference on the ground? And when we think about quality, I mean, I think we all know the issues there. It depends from journal to journal, from platform to platform, because we know that the quality of editorial checks and balances differs vastly across journals. There's no such thing as a rejected paper. You just haven't found the right journal yet that will eventually publish it, right? So eventually, kind of almost everything can kind of make it out there into the public domain at some point. So I think the issues of quality and quantity becomes, I think, quite tricky in the end when you have the average citizen trying to make sense of this kind of mass of facts. And I suppose it ends up with what social psychologists might call confirmation bias, is that we tend to then gravitate towards information that just confirms what we already know. Because I think as human beings, we don't want to change our beliefs too strongly, too often. Because we prefer to live in a world where our certainties remain quite certain. And I think that does then create a challenge for what we do with evidence. To use one kind of practical example, my colleagues and I did conduct a scoping review of LGBTQIA plus mental health research that was published over a 10-year period in the African continent. In other words, that there were African samples somewhere in one of those studies. And we were quite surprised that between 2011 and 2021, which was the 10-year period that we looked at, there were only 9 reviews published in the whole of Africa. related to LGBTQIA plus mental health. I mean, that's a shockingly low number. So while there is a proliferation of studies around what we might broadly call queer mental health, the amount of reviews collating this data is actually really, really low. And the quality of some of these reviews, I think, leaves much to be desired. And I mean, when we look at quality checks, if we had to evaluate them across certain checklists that have become quite popular when doing reviews, we find that many of them kind of lack very strong validity measures. For example, many of them don't even mention the databases that they searched in order to conduct the review. In some cases, they are merely called reviews without really specifying if they're a systematic review or a scoping review. In some instances, people don't even specify the countries from which some of these studies came, which made it difficult for us to know which African countries were represented within these individual papers in these systematic reviews. So that's just one example. But I think the benefit then, again, of systematic reviews is that they highlight the big gaps in knowledge. And what we found in our review was that there was not a single review in Africa collating data on intersex people from a psychosocial perspective, on asexual people from a psychosocial perspective, and that there was a really low number of studies looking at sexual and gender diversity amongst women, with an overrepresentation of data on men. So these are just some examples of where there are areas where we can improve in quantity, and certainly I think we can always improve in quality as well. I think I'll just pause there and hand over to my other panelists.
Great. Over to Carolina.
Hi, everyone. Sorry, everyone listening to me? Yeah?
Yes, we can hear you loud and clear.
Okay, sorry, no, it was something that happened here. Thank you very much for that question. I would like to also bring this to research evidence, right? So this issue of quality and quantity, particularly regarding, I'll give a brief overview of my work and where I got here with working with reproductive health. So I've been in the last 20 years working with, I'm a former journalist, and my focus has been on the role of communications for social change. So I've published books and I've done previous research on communications for development, particularly journalism, and the role of communications for social change in democratization processes, particularly with a focus in Latin America, and also work on the BBC and in Europe. So recently, the last years, I've moved on to look at communications for social change in the perspective of international development, and particularly regarding women's rights, which was something that was always, very clear. Particularly, it developed through the work that I did with students as program director of the International Communications and Development. Now, when we think about reproductive health, now this is an issue that actually has a lot of research in the field already, from sociology of health, from medicine, from public health in particular as well. Also quantity, I would say, it's quite pronounced here. And we see particularly now a discussion talking about COVID-19, how the issue of access to reproductive health has also become more discussed. And now in the US, in the context of the Roe versus Wade legislation and how that has played out. But in the area of health communications in particular, what I found with my work, and I've just launched a book which was a result of a Global Challenges Research Fund, which was a 4-year project, a large research, including PhD students from India, from Brazil, from the UK, as well as Latin America, is that the issue of reproductive health and how the quality of this discourse is debated in the public sphere is still very weak, right? So what we have, for instance, my work engaged with 52 NGOs from across the world. So these NGOs were in the US, in Latin America, in Brazil, in India, as well as in Europe, including CARE International UK, Amnesty International. So we had large organizations, we had short organizations. This was a mixed method research, including surveys which were applied to communication experts, also in-depth interviews to the gender experts. We did content and critical discourse analysis of the websites and the communications material, as well as their social media engagement. What we had, and particularly this work is very original in that sense, because it looks at the complexities of communications for reproductive health, and particularly how that works in practice. And it looks at this discussion within a wider context of the crisis of democracy as well, and the ways in which populist discourses and the whole emphasis on attacking women's rights and issues of reproductive bodies in particular, how that is playing out on the daily practices of NGOs who are working with communications on reproductive health. So the findings were very interesting that, again, talking about quality, what we have is that the discourse around reproductive health is very much restricted to echo chambers, to public health professionals, to those in the know. It's very medicalized, as well as even within feminism itself. It's very restricted. This was something that came also from the research in Latin America. There's two particular case studies in particular, which was Brazil as well as India. But in Latin America, this was raised quite a bit. So the discussion then was the complexities of how you engage with communication, an issue such as reproductive health, and how that applies on a daily practice. What are the challenges? What are the problems? What are the similarities also of communication practices across the board, right? So both India and Latin America, as I said, were interesting case studies and very different, right? So countries like Brazil share more similarities even with the US in terms of how the ideological manipulation around reproductive health discourses has a direct impact on the difficulties of NGOs communicating, the ways in which that they try to deconstruct myths, they use public health arguments, they feel themselves that are on very much a defensive, whereas the case of India is slightly different. It has a tradition of laws of more liberal laws around abortion, for instance, and it has a heavier emphasis on use of entertainment education, on digital storytelling. So there's also something that was widely discussed with the organizations, and they admitted that they are only using more communications and particularly digital media. So there was a focus also on digital and traditional media, and additional received a specific focus in our work. They argued that this is very recent, right? So like in the last 5 or 10 minutes, have they woken up to the power of digital media and how to combine this with their traditional offline communication strategies? So you have a type of communications such as Population Foundation of India, which uses entertainment education, which uses chatbots and creativity around communications, and you have that less so pronounced in other organizations. Yes, there are issues of large resources, which can fund organizations that have the means to use communications, but this is not just the whole picture. Some actually very creative, and they operate in a creative manner despite not having a lot of resources. So this is a very complex picture, and the findings were quite interesting, the sense of how many agree that the fact that there is a lack of quality of these discussions around the use of communications for how we can assist in advancing social change and progressive policies around reproductive health, and how this discourse is received by members of the public. And this I can actually answer in the other questions, particularly that's where my research now is going with some of the NGOs that are working with me that participate in this project now are partners. So there's one in the US, there's one in India as well, and in Brazil. And we are conducting now focus groups of communities to try to understand more how they are perceiving these types of communications, how they would influence a more participatory perspective, discussions that they feel that they don't have a voice.
Great. Yeah, we'll come back to that more. I can see in the next questions. Over to you, Kevin.
Great, thank you. Thank you so much for the invite to be involved today, and the joy of coming forth. I get to listen to everyone else's answers firsthand. So my background is maybe a wee bit different from some of the other panelists. So I'm a researcher at the University of Edinburgh. My work doesn't focus primarily on health, but looks more broadly at questions of how we collect, analyse and use data about lesbian, gay, bisexual, trans and queer communities. My work does dip its toes into a variety of different areas. It's evidence and data around education, around housing, around outcomes, around healthcare. but also kind of zooming out and thinking more broadly and applying a kind of queer lens or queering the approaches we use in any data gathering, analysis, or presentation tools. So I guess my answers are going to be a little bit more general, a little bit more abstract, but thinking through some of the conceptual and philosophical challenges that accompany questions around evidence and data. And in particular, centering the communities who are behind these numbers, these testimonies, these pieces of information, the lives and experiences that actually constitute what we describe as evidence. So my answer, I'll take us through kind of discussions around quality and then quantity. I think it's a fantastic question. It's really opened up for me a huge amount of different paths to go down. So I'll try and just pick out things which spoke to me the clearest. So in terms of quality, there's a great comment in the chat box from Bankole about what counts as evidence. And this has been a real key element to my work in recent years around evidence and data on LGBTQ communities in the UK. What counts as evidence? Who determines what counts as evidence? And how is that evidence then used to bring about change in good and in bad ways in the context of recent political developments in the UK? I'm interested also in how what we kind of conceptualize or define or understand as evidence or data has a politics, has a history, has a power. So I'm currently based in a business school, but my academic background is actually in history, and I'm really interested in the kind of history of data and the history of evidence, and how things which are now presented to us as being apolitical or being neutral or being value-free, actually within that, there's a huge amount of kind of political and historical kind of discussions baked into them, particularly when it's evidence around the lives and experiences of minoritized and marginalized groups. So when it comes to the question of quality, it kind of begs the question, is poor quality evidence or a poor quality database, to what extent does that relate to the historical experiences, the historical situations and contexts that those communities have found themselves in? So thinking about my work, for example, on gay men in the UK, the kind of data and evidence that exists about gay men in the UK is very much determined by the history of these data collection institutions, agencies, and powers that be. So for example, I did a small project looking at what quantitative data existed about gay men in terms of police, healthcare, media coverage. And as you can imagine, most, if not all of that information was extremely negative. It was documentation of criminality, of deviancy, of being kind of subhuman to some extent. So when we think about that historical data set, that history of data that exists, and how that kind of historical data has contemporary effects on today's evidence systems, on large language models, on AI, generative technologies, all of these contemporary technologies are making use of these biased, one-sided historical data sets. So I think it's important when we think as to why data is collected or why evidence is gathered, it's routinely collected and gathered to demonstrate evidence of a problem or something that people in positions of power perceive or understand to be problematic. That means that when we look at marginalized or minoritized groups, whether it's along lines of gender, sexuality, race, disability, age, the data sets that exist tend to only paint one side of the richness and full diversity of these groups and communities. So I think the word quality has a lot of politics, a lot of subjectivity baked into it in terms of what counts as quality and who determines what is quality, and the kind of contemporary effect of the histories of these groups. So I think quality is fascinating. I then got carried away even more so when thinking about quantity. So a big argument in my work is thinking through, when do we have enough data or evidence about an experience, a community, a problem, and when do we need more data or more evidence about a certain problem? And how, as researchers, as practitioners, as policymakers, how can we determine when to make that switch between collecting more data and more evidence about a problem and actually using our existing data sets to crack on and get on with the job? So I really liked Suntosh's earlier example around mental health of LGBTQIA+ people in Africa and the absence of data and evidence on that problem, and the need in those situations to perhaps go out and collect more data, more evidence on those experiences. In my work in the UK, I do a lot of work within universities, within the higher education sector, and the data that they collect and the evidence they gather on staff and students, particularly along lines of gender, sexuality, race, and disability. And often in those contexts, there's actually quite a lot of evidence and data on the lives and experiences of those groups and communities. So too often in my work, I see calls for more data as being a stalling technique or a means for people in positions of power to kind of pause or put off the harder task of cracking on and solving the problem, and instead kind of commissioning, putting more money into data gathering, data collection, expanding data sets, plugging gaps and absences is a term I hear on a weekly basis in my work, and how sometimes those efforts to plug gaps and absences can actually be a means of postponing more meaningful work to address structural and systemic problems. So I guess my kind of call for everyone would be just to kind of think through, when does your organization, when does your employer, your institution, when does it actually need more data or more evidence about a problem? And when is the call for more data actually being used as a technique to postpone or to kind of stop more meaningful, harder to do work from taking place? So I think both with quality and quantity, there's a huge amount of fantastic complexity baked into that. And I'm keen to see how this plays out and how this interlinks to the other questions, and also to hear from those in the call today and those in the chat about their experiences of navigating that tension between when do we have enough data and evidence and when do we need more, and when do calls for more data sometimes stop us from getting on with the harder to do job of fixing the problem.
Very, very excellent, very provocative. So just to pull out a few of those things and tie them together as we move on to the next question. And I guess what struck me as a data educator, so we train kind of through the gathering, collecting, analysis, storytelling phase. And I thought it was great to start with this question of synthesis and scoping, and then to look at the two ends of that, right? So from the question of what is the quality and quantity of the synthesis of trying to bring it all together, well, then we've raises the questions that Carolina and Kevin were kind of resonating on around, well, how is it gathered in the first place? Is it even there? And then when we get to the end of the chain, where we're meant to have public knowledge and policy and decision-making, if we have bad syntheses and we have political issues in our data collection, then what we're going to end up, as one of our PPIE participants put it, rubbish in, rubbish out, thinking about kind of the sort of questions of health research today. So I think on that note, leads well to our second question.
Thanks. That was such a great first round. So there's a lot of material there to think with. So what we asked our panelists to reflect on next was, okay, we've already got a sense of a picture of the challenges that face us in thinking about quantity and quality in relation to the data that is generated through research from multiple disciplinary perspectives in relation to health and well-being. So the next prompt for the next round is, we'd really like to hear from our panelists from the perspective of your research, your experience, your particular disciplinary expertise. What does it take for data to be considered compelling by those who are in the position of being able to do something to improve health, to improve well-being, to deliver on cures, on medicine, on healthcare, right? So from your perspectives, in the research that you've done, in the positions that you're sitting in, who are the people in power? And what kinds of data do they typically act on and not? And what are potentially the obstacles to, as Kevin put it, getting on and getting the job done of making sure that people get the healthcare that they deserve? So there's a lot of questions there, kind of all rolled into one, but really the summary of it is, what does it take for those, what kinds of data does it take for those in power to effect positive change? And we'd love to hear from you, from your perspectives. And let's go in the same order that we did in the last time to keep it simple. So over to you first, Tamara.
Thanks, Mehita. is a very complicated question, and it's got a lot in it. So the first thing I was tussling with was the who is in power. And it took me back to, so the kind of lens that I work through, I'm not a communication person, but I work in a field called knowledge translation or research translation, where communication is an element of that. And it's really about how do you bridge what we know and then what people do, either in policy and practice. And so in that framework, we often try to break down who are the role players. There's the, who's in power, how much power do they have, who are the champions, who are the blockers, how do we make use of the different role players in the evidence space. So that it kind of made me think of who, and I settled on thinking about policymakers. That's, I could speak from the researcher perspective, but the partner that I work most closely with would be government, particularly in the Ministry of Health and and with multilaterals like the World Health Organization. So I'm going to come back to that in a moment. Because you also asked, I think, the biggest obstacles facing those in power to enact change. So the other bit that I think is really important to unpack is decision-making. So decision-making, even if you have evidence, what's the process of decision-making? It's a non-linear, circular process. I think, Suntosh, you talked about, people, it's difficult to shift people's views too much. And so it's really exciting. And one of my roles is working with the World Health Organization guideline panels, with very diverse panels representing policymakers, implementers, ethicists, patients and the public, to develop consensus around quite complex issues, but it's usually around clinical care and treatment, whether it's malaria or TB or HIV. So decision-making in itself is a really interesting space to think about. So what are the biggest obstacles? So I was pulling up some memories around work with policymakers. We did a project called Policy Buddies, where we specifically buddied up. We thought one of the ways to bridge the gap is to buddy up with policymakers. So each researcher had a policymaker in the provincial government, and whatever their questions were, it wasn't so much for us to go and answer those questions, but to work alongside them to help them navigate, for example, which databases they might search, what would be reasonable search strategies, how do they find scoping and systematic reviews, and then appraise whether they're any good, because we've all just realized that systematic reviews are not all born equal, and there are a lot of bad ones out there. So that was an interesting project. And in that, we really had to lift out what are the key barriers for those people we worked with. But globally, there's a lot around what are the barriers for those people in power, working in policy, having to make decisions in the health policy space. I think the big issues that often come up are access. People don't know, they don't have time, and they don't know where to access information. They can't read and understand the scientific literature. I'm sure none of this will be news to you. People have competing priorities and different skill set. So, and sometimes costs can be a barrier. And also, in our social environment, what are the social norms? Are other policymakers around them also looking for evidence, or is everyone just kind of quickly getting on with the job? Which makes me think of what Kevin was raising, which I thought was, Kevin, you raised a lot of interesting questions, but one of them was, plugging the gaps and absences. And I kind of thought, I'm not sure I have that same experience that you get this weekly plugging the gaps and absences. I have more the experience where people are just trying to put out the fires, and they're not asking for any evidence or any gap, plugging any gaps. So it's kind of the reverse way around, where people are getting on and doing things and not always doing them based on errors that have been made in the past or things that we can learn around. Okay, so I finally wanted to say, so in this field that we're working in is, and where the policy buddies and that kind of work comes in, is a field called integrated knowledge translation. And that is basically IKT, or integrated knowledge translation, is building relationships between researchers, decision makers, for the mutually beneficial use of research evidence. And I think that that field of integrated KT knowledge, building trust, building relationships, is really the core of my day-to-day work. And in a way, I call myself a knowledge broker, is my other hat. in this IKT world, and that's how we get the work done, through trust, through relationships, and then credible synthesis of evidence. So I think I've touched a bit on the question, and I'll hand over to others.
Thank you. Those were some gems of insight there. So your turn, Suntosh, to reflect on that challenging prompt. Over to you.
Yeah, thanks, Mehita. Yeah, it is a complex one. I mean, I suppose we could spend the whole webinar just talking about this very question, because, like, to some extent, it is like the $1 million question. Like, how do we get people in power to actually take evidence seriously? And I suppose for me, the one question was like, who do we consider people in power, right? Because quite often the assumption is that they are these kind of policymakers out there. And in some cases, they might be official policymakers or legislators. And in other cases, it could just be people who are in the very system that one works in. I mean, I've worked in a public hospital, for a very long time, over 10 years, and being at the coalface of service delivery as a psychologist, I would have considered myself someone in power, because while I'm not writing official government policy at a provincial or national level, I'm creating kind of departmental policies and decisions makings on an everyday basis that then impacts directly on patient care. Right? Which means if I use an example of how to respond to a person who is suicidal and comes into a public hospital psychology department on an average Tuesday afternoon. I mean, I might have some sort of policy within my department that I work in. This may or may not be based on what the latest systematic reviews show on how to work best with suicidal patients. It might be largely based on pragmatics. How many staff members do I have? What time of day is it? How many other patients I have to see? Where do I kind of triage this particular patient in relation to other patients? So I often find that the kind of hierarchy of power can also be quite a kind of complex one as well. And even if there is some sort of provincial or national or international guideline on this, whether it filters down to the average practitioner like myself, who is literally interfacing with members of the public who need healthcare, is a different story. In the last year or so, I work at a slightly higher level of the healthcare system, where it is possible for me to kind of write policies. And kind of being a researcher anyway, again, evidence becomes complex, because I think Tamara used the perfect phrase, which was putting out fires. I'm not sure about the health departments in other countries, but certainly it's in the South African context, and especially in the province that I work in KwaZulu-Natal, quite often we are largely spending our time putting out fires. And rather than being a proactive healthcare system, we are quite often a reactive healthcare system. And in an ideal way, we would hope that people create policies based on the usual chain of evidence creation. But to use one of the most tragic examples that I think all South Africans would be aware of, 9 years ago, the Gauteng Health Department, one of our provinces, decided to move 144 patients. Well, actually, they decided to move more psychiatric patients out of a private healthcare facility into non-profit organizations. The result of that was that 144 people died. And it's probably the biggest scandal in mental health care in South African history. And one of the reasons was because this wasn't an evidence-based approach to what we normally would call deinstitutionalizing psychiatric or mental health care users. And that's a perfect example then of where a need to save money then trumped any kind of evidence-based planning and evidence-based healthcare, resulting in the actual deaths of patients. So even though there were calls and letters written to the Gauteng Department of Health by reputable organizations who got wind of this before it took place, it fell on deaf ears. And the result was that we had a tragedy that unfortunately has now become a reference point for kind of how not to ignore evidence and how to create evidence-based policies so that things like what we now call the life Esidimeni tragedy don't happen again. But it's unfortunate that we have to kind of get to those points of tragedy, before evidence is actually taken seriously. And proactive calls to create policies and to manage services in ways that are kind of science-led don't actually happen until we actually face these kinds of fires. I'll pause over there because there's a few other things I can say, but in the interest of time.
Thank you so much, Suntosh, and I'm glad you brought up the life Esidimeni tragedy, which is really one of the biggest stains, I think, on our healthcare system in the democratic era. I'll post a link to that so those who are not from South Africa can catch up on that particular tragic case. But let's move on with the conversation. Over to you now, Carolina.
Okay, thank you for that. I'm just going to make a connection with what I was saying before, because I think it's important in terms of research evidence before we move into this question in particular. One of the areas that it is growing within discussions of reproductive health in the field of health communications is precisely the ways that medical providers, doctors, and whole institutions of healthcare are finding it difficult to pass information to the public. And so recent work now on social media and misinformation around health and so forth, and the ways which there is anxiety around that. Recently, I've actually been asked to talk by some providers in the US about my work regarding that. And that's kind of a contrast to what I got from the findings of my work with the NGOs from across the world, was the ways in which that they argued how they had lack of funding and how they were struggling in the middle of numerous challenges, particularly communicating better, right, about reproductive health to the targeted publics, making people understand more of this topic beyond the manipulation around feminists wanting to cultivate a death culture and so forth. And you have now a growth of studies about, for instance, contraceptive videos on TikTok. One of my focus groups in Miami, for instance, recently, the participants talked about a lot of misinformation that they found online about this topic from across the board. So there is a discrepancy between what is actually happening among the more medical institutions, those who have the power, and the ways in which a lot of the NGOs that work in the area of health highlight how they are up against a system of very funding scarcity. They have very little that they can work with, right? Particularly, this is not so much the case of some of the large organizations, but particularly the ones that are working more at a grassroots level have emphasized that quite a bit, both in Latin America, in India, and in Europe as well. And the ways in which that they think this is then something that makes it more difficult even for some of them who argue, and the work of previous scholars here in the UK have also touched upon this regarding health NGOs. The difficulties that sometimes some would like to enact more positive change, would like to make use of their policy programs to actually contribute to advance gender equality, but the ways in which that they fear that they cannot advance, they can only go so far, right? So the ways in which also there are self-censorship practices, and some of the things, censorship was something that came across quite a bit throughout the communications, in particularly the ways in which it was discussed in a different way depending on local context. So this is, someone has said about the $1 million questions, how can actually we enact change given the challenges that we face, including the lack of resources?
Are you done, Carolina? Or
yes.
Okay, lovely. Thank you so much. That was a wonderful set of observations. So over to you now, Kevin, to weigh in from your perspective.
Great, thank you for that. What a fantastic question this is. I've just got so much notes I'm trying to kind of digest and think through. I think it brings us to a fundamental question around what does data do and what can data and evidence achieve in bringing about kind of changes in the world around us. And this is a kind of thorny problem I've been really trying to navigate within my work on LGBTQ political and policy issues in Scotland and the UK. So in my book, Queer Data, I write about how if you imagine a society that has the best evidence, the most extensive data sets on LGBTQ communities, these data sets might be quantitative, they might be qualitative, they might be disaggregated, they might be intersectional. But the quality of that data set doesn't mean that the society is necessarily the best place for LGBTQ plus people to live. And I think that disconnect between having evidence about something and actually being a place where the material conditions, the day-to-day lives and experiences of those communities is positive, isn't always the same. And this became really clear to me through my work in Scotland around a piece of legislation called the Gender Recognition Reform Bill. So this was a very hotly contested piece of legislation from a few years ago, which very simply tried to simplify the process by which trans people could change the sex marker on their birth certificate. The legislation went through Parliament. A huge amount of evidence was gathered around the positives for this change in the legislation. Across a range of academics, experts, policymakers, community groups, we're talking about boxes and boxes of high quality evidence here. But ultimately, the legislation was not implemented. It was defeated through a kind of chain of events involving the UK government. So this really got me thinking. There's a stage in the process in terms of how we change things in the world. I think we maybe imagine that ideally what happens is we identify a problem, we go off and we collect evidence about that problem. We then take that evidence, that data set, that kind of list of academics, of experts, of people who can kind of inform our discussion to people in positions of power and listen to us. But that final stage of the process isn't happening, at least in the context of the UK. Policymakers, people trying to change legislation, are hitting a brick wall where, irregardless of the quality or the quantity of the evidence we have, changing the hearts and minds of people who ultimately make decisions about our lives and their experiences is often really difficult. And I'm not quite sure how we get beyond that stage. My concern is that we continue to try these old methods where we just keep on collecting more and more data, more and more information, under the impression that if we just had this golden piece of information, it would somehow change the hearts and minds of those in power. I increasingly don't think that's the case. So more and more my work is becoming interested in a topic we've discussed a fair bit about, around communications, around how do we communicate and share ideas about evidence and data in ways that does change hearts and minds. And also, how do we use data and evidence in politics in ways where it might not necessarily reflect the full accuracy, the full picture of what we're discussing, but it plays a strategic role in kind of changing these discussions. And one final thing I wanted to flag around this kind of how do we use data in ways that compels action. I think there's also contained within this a trap. And what I mean by that is things working almost the wrong way around. So if we believe that we can change senior leaders, decision makers, people in position of power, if we believe we can change their mind by presenting a certain piece of evidence or a certain piece of data to them, it then means we have to change and contort and kind of reframe our lives and experiences as data subjects in ways that speaks to those in positions of power. And contained within that are some really dangerous elements. So thinking about my work on LGBTQ communities, if we believe that politicians were more amicable to data sets that only spoke about experiences of white, non-disabled, lesbian and gay men, we might therefore feel that we have to go off and collect data sets and evidence that paints a very narrow, a very exclusionary, a very kind of inaccurate representation of the full complexity and diversity of these communities. So I think there are some risks and dangers about jumping through hoops that we think people in positions of power want us to kind of satisfy. And ultimately, at the level of the people and the lives and experiences of those who are being counted, where are there some risks and dangers about potentially excluding, cutting, splicing, kind of contorting these experiences in ways that we think will be an easier sell to be changing hearts and minds, but actually involves really problematic practices at the level of who counts. So a few ideas there in terms of this big question about how we use data and evidence to change the hearts and minds of those in power.
Thank you so much, Kevin, and to all the panelists for those contributions in this round. I mean, such a wide-ranging discussion. And to be honest, I'm quite interested at how little critique has actually been sent to those who are supposedly in power. And I think that really highlights the question of, well, what is power and who actually has it? And assuming that those in policymaking or political positions have power and wield it may be a kind of red herring, and that, you know, the keywords that have come up are consensus building, trust both of information and of the different actors at play in decision making, and the different institutions that are involved, right? From government actors to non-governmental actors to individuals to researchers. And all of those different actors have a different relationship to the evidence, how it's produced, and what they believe they can do with it. So this is a good moment, I think, to segue into our last round, which Anna is going to introduce for us. So over to you, Anna.
Okay, great. So we always like to end on a question about empowerment and resistance. So just before I start off this question, just to say, if you do have questions, get them into the chat now, and both the speakers can, when not speaking, can have a look to see if you've addressed a question to one of them and answer you in the chat, and then we'll try to stack some and at least get a couple in before we have to end today. So also just to ask the speakers to keep these ones tight so we have some Q&A time left. So in your experience, how has or can evidence about health be used as an instrument of empowerment or resistance by ordinary people? And we'll start again with Tamara.
Oh, I'm so deep in the reflections and all the information I've been receiving. Thanks, Anna. Thanks, everyone. And also the chat inputs are really interesting. So evidence, I think we've established evidence is powerful, is contested as making sense of what is research evidence and how it all fits together. In one of my favorite interviews, when I was doing some work asking people about how health policy is developed and implemented in South Africa, kind of at the point where the National Health Insurance bill was going around, the white paper and the green paper, and one of my favorite lines was someone saying, you can bamboozle people with evidence. So it's like that fancy footwork of the boxer, you know, you can run around people. And in the field of evidence-informed decision-making, evidence-based healthcare, you know, there's a set process around how evidence can be used and how we make sense of evidence. But in the reality, there are multiple kinds of, it's not evidence-based healthcare. There are terms like eminence-based healthcare. So who's the most senior gets the last say. Vehemence-based healthcare, which is kind of who's the loudest and shouts you down. Eloquence-based healthcare. So really, you know, you can wield your numbers and convince people. And so the really, you know, in hindsight, the people I respected and trusted most when I was working clinically were the people who read the systematic reviews, rather than the people who cherry picked their own papers or other things to support their views. Or, you know, that, yeah. So how can people, so I think this is a major gap in our, if I come to my day-to-day world, which is thinking about national health insurance and how evidence is used to inform decision-making around the benefits package and the healthcare that people should access and the way they should access it and where they should access it, we have a massive gap in public participation. In fact, we have a complete absence just about of public participation in that process at the moment. And I think it's a really interesting and important area that needs a lot of consideration, to ask people, how do they want to participate? In what format? Do they want to sit on these guideline panels or policy panels or committees? Do they want to be engaged through, different participatory methods and workshops, webinars? What are people's preferences for how they participate in these panels? And I think there's a lot of work. Maybe this, Kevin, is my filling the gaps and absences and not getting on with the hard work. But understanding people's preferences in participation, I think, is an important question to ask. I think I might stop there, just because I think in my day-to-day world, other than thinking about how we package information, how we package evidence in different ways for different actors or role players and people who use it, which we do in all different kinds of ways. I think for me, the biggest gap is that public participation in decision-making. And in the absence of that, I think I will rather listen to what others have to say. Yeah. Over to Suntosh, our chair.
Yeah. Go ahead.
Yeah, thanks, Tamara. Thanks, Anna. Yeah, I'll just maybe build on one specific example, because I think it leads nicely also from what Kevin spoke about earlier around kind of how these calls for more data can often be a bit of a red herring, and actually kind of distract us from actually the kind of real work that needs to be done. And I think in particular, if we're thinking about things like emancipatory healthcare, how it can delay or subvert social justice and health equity. And for me, one of the most prominent examples I could use in the field of kind of LGBTQ plus mental health is the Anti-Homosexuality Act in Uganda that was passed as a piece of legislation last year. And one of the hats that I wear is, that I sit on a long-term project called the African LGBTI plus Human Rights Project, which is situated within the national psychology body in South Africa, the Psychological Society of South Africa. And as far back as 2009, when the Ugandan president Yoweri Museveni proposed the anti-homosexuality bill, one of the strange things he did was he put out this call for evidence and said, well, if you can show me the evidence that being gay is not unnatural, and is actually not bad for families and for children, then I'll get rid of this bill. And we've seen this in numerous countries around the world. But I think Uganda was a particularly kind of instructive example, because 15 years later, we saw this bill still hanging in the air. And in fact, last year actually got signed into law. It's one of the most horrible pieces of anti-queer legislation in the world, and flies in the face of all credible evidence that one could find around what is affirmative healthcare for queer people. And the Psychological Society of South Africa has been engaging and writing these open calls, these open letters, these consolidations of evidence pieces. We've produced our own set of guidelines around how mental health professionals should work with queer people, which is the only such guidelines for psychologists in South Africa and Africa more broadly. But all of this evidence has fallen on deaf ears. In fact, this particular legislation in Uganda eventually got major scientific authorities in the world to write open letters signed by people like Glenda Gray, Linda Gale Becker, etc. We've had the Ugandan Academy of Science, the Association of South African Scientists. So it's a good example of how what that legislation did was create resistance, not just from Ugandans on the ground whose real lives were going to be affected by this, because they could go to jail for merely identifying as gay or lesbian or transgender, but also resistance from the scientific community, largely across South Africa, because we are a space that would enable that kind of resistance, but also internationally, because you had international organizations citing their own concerns around this. So I think in some ways, a lack of evidence that makes it all the way to national legislation can ironically then trigger the kind of resistance and the kind of broad-based public movements that we often need in order to generate better evidence for the future. Much like the Life Esidimeni tragedy I spoke about. That becomes a now reference point for how, as scientists and practitioners, we need to do better. But again, it would be great to live in a world where, we were more proactive rather than reactive. But I think these are some examples that I think give us more food for thought. I'll pause over there.
Great. Over to Carolina.
Okay, thank you for that. I'm going to connect my answer with what Tamara was saying about participation and how people should participate. So a key evidence from the work was that a lot of the communities affected felt they were not participating and engaging totally with the health communication campaigns on reproductive health. And there was an issue also that the communications that was coming from the organizations was very top down still, despite some mobilization, some community engagement, but an overall very one flow kind of process. So now currently with the partners that I mentioned in my previous answer, as well as researchers in the UK and the US, we are submitting a grant application for a larger fund to conclude our work, which is exactly to try to answer that question and engage more with communities. We've already, I mentioned in the previous answer, we already started to do some of this through resources from the previous work in the US, in Brazil, through Rep Latina, as well as in Guatemala, through the US organization Saving Mothers. And we engage with midwives in Guatemala who exactly highlighted the ways they would like to participate in these discussions. So they would, a lot of our focus groups and our engagement with the communities is already showing that they want these safe spaces, they want further training. I'm developing an advocacy communications plan with one of the organizations, also submitting the results through an NGO toolkit, but particularly they also feel that they want to participate on their own terms. So respect to their languages, also to their culture, and to the particular local context, which they feel that this is not happening. So I think this is an important area to research further, the ways in which community engagement and more participatory methods in health can actually lead to what we want, to issues of social justice. We're talking about emancipatory health, right? So I think one of the things that the lead from She Decides here in the UK argued was that the discourse around reproductive health, my book also provided a historical context from the debates from the 80s up to now, with their organizations in the United Nations and so forth, with issues of women's agency and bodies and so forth, they've become marginalized, right? They haven't been taken that seriously. So we're still at that discussion. How can we move this forward? And I think this is the question that we're trying to address currently in my research.
Great. All right, Kevin, to round us off.
Right, thank you. And I'm going to continue this theme of building on Tamara's point about participation. I think it really sums up this question around resistance and empowerment. I'm interested in thinking through what do we do with people who don't want to participate, or people who are ambivalent about data gathering exercises, evidence gathering sessions, or actually in my work with LGBTQ communities who have lost all faith in institutions, government agencies, healthcare providers, that actually they want to subvert, they want to refuse, they want to abolish the institution, the system that's trying to collect more and more evidence and data about them. How do we create space in our work to acknowledge their existence, their agency? What I see at the moment is that these communities, these individuals are cast as being difficult, they're being awkward, they're cast as being stick in the mud, or to quote Sarah Ahmed, as killjoys, as people who don't follow the ways as things should work. And for me, what I'm interested to look through in my work, in my research, is how this kind of demand for participation creates a veneer of inclusion, where people are told that you're included as long as you participate in this way, or as long as you jump through the hoops that we ask of you. And how actually, as a form of inclusion, that's not really inclusion. That's partial, that's piecemeal, and that's driven by the demands of those who are already in positions of power. So I'm keen to think through how any attempt to gather more evidence about marginalised and minoritized groups, we create spaces for those who do wish to refuse, to subvert, to break the system that's trying to capture information about them. I think particularly when many of these communities have lost faith in these long-established, often historical systems, which often don't have their interests kind of foregrounded. So I think that was my main kind of point around resistance, around empowerment. How do we ensure that those who are presented as being difficult or presented as being killjoys aren't doubly excluded or fully removed from these kind of evidence gathering practices, when often the system or the institution has failed them rather than the other way around?
Yeah, great. So much to think about there. So please do, if you have questions, get them in to the chat. And then just something that struck me in tying, I guess, a bit of that together with a comment from Mona in the chat. Mona's had to leave, but that a few people had responded to, like it. I think with this question of participation, it's like then when you do more community-driven or creative modes of participating modes of participation, even for health projects, it then produces evidence that is not counted as evidence because it's not clinical evidence, it's social science or creative practice. And so then, it gets like excluded from the metasynthesis because, it doesn't pass the validity checks that come from a more STEM or quite hard social science perspective for anyone in the audience who's ever done one of those validity checks. I've done it once as a social scientist, and it was really terrifying how much our disciplines and qualitative research was belittled in them. So it's to me, it produces this kind of like, I don't know. I mean, I guess the question in that is like, do you think there's any way out of that? Do you think we are making some progress towards having more alternative types of evidence collection, counted or considered? And like, do you think we're going in the right direction or not yet?
Can I chip in?
Yeah, no, as a question to the floor, yeah.
Okay, not rhetorical. Okay, that's good. So in the area of health policy making, we are very much, there's different kinds of, there's health evidence, like does something work? You want to know if something works or not. Is it safe or not? I mean, that's obvious. So evidence, that part of evidence is one part of it. But in the guidelines world and decision-making world, there are other forms of evidence that are increasingly not completely being recognized as equal, but increasingly being recognized as equal. And those are the, I guess you could call contextual factors. Is it acceptable? Is it feasible? What is the impact on equity if you were to introduce this intervention? What are people's values and preferences around the outcomes that we chose as the researchers or academics? Do people also value those outcomes? How, so there's more and more work. And so, I mean, I'm loving the work that's coming through on qualitative evidence synthesis, understanding the credibility, the confidence we place in thematic findings, bringing tons of amazing rich data together. And during COVID, when we had all that rubbish effectiveness, terrible trials of 10 people, in fact, it was the contextual evidence, the equity evidence that often drove our decisions. So if that is helpful in any way, and I'm seeing that more and more, when we neglect those contextual factors in the big health policy decisions, we make mistakes. So, yeah. Sorry, passion.
Yeah, no, it's really interesting. And I think, I know Abir, who's just made a comment, and I have had this discussion about the need also for doing that kind of scoping qualitative reviews and not just leaving those to be, the more clinical or statistical types of meta-analysis. I'll turn to Mehita's actually technically leading our Q&A, so I'll turn.
Yeah. Well, I was just going to say that, the discussion has been so rich, and our panelists have all, been so generous with their insights from their particular positionalities. And we really only have a few minutes left, so we're in this kind of difficult situation. But is there anyone who's contributed to the chat who'd like to kind of throw in a comment or a question? I'm sure all of our speakers have been looking through the chat. I noticed a couple of you have already been replying and adding your thoughts. Yeah, I think one of the big themes that's come up in the chat and the questions that have been raised is, precisely what you noted, is that tension, but it can be a productive tension, of course, right? Between the classic epistemological approaches, the quantitative, the qualitative, double-blind trials versus the more interpretive and exploratory data. So, Anna, I don't know what you think, but I was going to, if there is anyone in the audience with a burning desire to pop up their hand and say their piece, please do feel free. But I was going to, if there isn't, and I'll wait and see if there is, but if there isn't, we could maybe just give our speakers each like a last, 30 seconds to a minute to like wrap up with a final statement or a final provocation or a final question that they would love to see others doing work on. I don't see any hands up in the audience. So I think, for questions of time and to not put anyone on the spot, let's perhaps just move to a final statement from each of you, and we can then wrap things up so that we don't take any more time. So Tamara, you're up first.
So can I go last?
Yes.
I don't have a wrap-up sentence.
Go last. That's fine. Suntosh, are you ready to roll if you have any last final thought?
Yeah, I'll just throw out some things. I think firstly, just thank you for the for convening this conversation, and thanks everyone for the comments in the chat as well. I think that there's so much to chew on in this area. I think I'm left with a couple of thoughts. So the one is, I think as researchers, policymakers, policy implementers, etc., there is a focus on kind of written evidence, and I think part of what we also need to move towards in kind of knowledge translation and related science communication is looking at the visual a bit more, and how we can use visual means of communicating evidence, especially for politicians, policymakers, funders, etc. This could be a personal bias, but there does seem to be like a lack of reading or a culture of reading that is developing in an increasingly visual time, and I wonder whether if our evidence was on TikTok, it might make more of a difference than if it was exclusively, sitting in journals or even as nifty infographics, etc. Yeah, so I think that's one of my thoughts, is just kind of how we translate a lot of this evidence and knowledge into different spheres of influence for different publics, etc. I think lastly is this issue of kind of competing resources and demands. That a lot of the time, what I hear in my space around mental health is that there are so many competing demands for the treasury budget. And even though we know there's evidence around implementing, these kinds of good practices in healthcare, we also have this and this and this. And I think using evidence to find ways to have the conversation about how do we allocate resources meaningfully so it doesn't become an either or, I think is also an important conversation to have. Yeah, thanks.
Absolutely agree on all those points. In interest of time, let's move straight on to Carolina. I think you're up next.
Okay, very briefly, first to thank you for this invitation, and the participation in this webinar has been great. I've really enjoyed taking everything in, so I'm actually looking forward to listening to the recording. So just also following on a quick point, I think some that were raised also here in the chat, and I feel that this is something that I'm also attempting to do in my research. There's been a lot of discussions about sociologists and academics from the social science and how we can collaborate more with the medical field and so forth. I think this is something that perhaps is growing more. I think the interdisciplinarity aspect, for instance, is quite strong in my work. I'm working with people from the public health, medical staff, also from the University of Miami and Florida International, and also communications and sociology. I think these, and recently also we hosted a webinar when I was in the US with Daniel Helene, who also works in the field of health communications, some scholars for medicine. I think this is still a challenge, but some of us are kind of trying to do that, trying to make inroads with the medical community, doing more interdisciplinary work, having these perspectives heard. People talked about issues of evidence and what constitutes a scientific research and evidence and so forth. So I think this is a bit the way forward. Yes, there are issues of power. I think the point of power in this webinar was a very good one, and it kind of thought-provoking, and it makes us think more how we can disentangle more of these institutions of power moving forward, particularly through our work and what we do. So just very few points there following from the previous discussion.
Yes, very important points. Thank you, Carolina. Kevin, over to you for your final thoughts.
Oh, yeah, I was too busy typing away in the chat. My final point, I'm going to keep it super short. I'm just interested in how, and this is a focus of my kind of ongoing research and writing, that kind of looping effects between the evidence collected about different communities and how those communities come to make sense of themselves. So again, my work on LGBTQ communities, I'm interested in actually how these data sets, this quantitative and qualitative information, doesn't reflect the pre-existing reality. It actually loops back and shapes and changes how we think of ourselves. And I think that back and forth between evidence and the communities that evidence represents is a really interesting area of work. There's a long history of that work in science and technology studies, but I think we can take some of that learning and apply it to the contemporary experiences around marginalized and minoritized groups, and think of evidence not just operating in one way, but actually reflecting back to ourselves how we conceptualize and define our lives in today's world.
I love that notion of evidence as a form of representation. Yeah. So over to you, Tam. So I keep calling you Tam. Tamara, Professor Kredo, your final word.
Yeah, no, I'm sorry I didn't let Kevin do the final word because he's always so cogent, but my plea would be to those of us working in research and academia is that when you have a question in mind, to go to the people who might use that evidence and ask them if your question is the right one and see if you can refine it a little bit further. And I mean, ideally work with them alongside and keep them up to date so that when the research is ready years later, they might be able to use it. But really just working with the end users of that evidence, whether it be the public or a policymaker, they're just people, and I think that's an exciting relationship to build. Thanks.
Absolutely. I think that's a call to action that can be taken up by researchers from every discipline looking at almost any question, right? If we say that our research is meant to be contributing to a better world, a more just world, then it has to find new ways to be inclusive. So thank you for that, Tamara. And I think we're just a couple of minutes over our scheduled end time. We're conscious that our esteemed and beloved panelists probably have a massive workload to still attend to for the rest of the day. So a very warm thank you to all of you who signed in to join the conversation. It's good to see all your names popping up in the chat and to hear your views. Please stay in touch with our work and what we do. And yeah, just another very warm thank you to Suntosh, Kevin, Carolina, and Tamara for their insights and their time. And is there anything you want to add?
Thank you just from me as well. And thank you to, I think he's gone off screen, but our behind the scenes, our man who makes it behind the scenes. So which this one's come together without the support of the Mehita Center and colleagues. So thank you very much.
So awesome. Colleagues, in due course, we'll get a write-up, a draft kind of essay of this prepared and circulated to you for you to check and for you to see if there's any input you want to add or citations. And hopefully over time we can get a version of this published to share widely. We aim for an open source journal. The moment we're in talks with the South African Journal of Science, which is a really nice open source interdisciplinary esteemed platform here in South Africa. So we will try our best to get that out there. But we know you're busy. We thank you again for your time. So feel free to just log off and disappear. But if you want to linger for a last chat, we'll be here for a few more minutes. Bye.
Thank you, Anna, Mehita. Thank you, everyone.
Thank you, Carolina. Great to see you.
Good to see you.
Thanks, Tamara. You're awesome.
Great. Thanks, everyone. Take care.
Thanks, Suntosh. Say hi to the Indian Ocean for me, please.
Will do.
Okay. Is it just, I see one by one people are leaving. That was great. I hope as I was, and I hardly slept last night, so I was a little bit incoherent. I hope